Good afternoon. Welcome to the Lung Cancer Institute updates for 2026. This is very important information for all of us from our physician panel series. Today's topic will be colorectal cancer. Prevention starts early and understanding colorectal cancer treatment. We'll be learning today from our amazing speakers, Dr. Andrew Ross, colorectal surgeon, Dr. Samuel Cariff, medical oncologist, and Dr. Ross Taylor, radiation oncologist. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, the expertise of our staff, and as we're seeing today, the benefit of our multimodality method of treatment, all combined will truly save lives. In the interest of time, our speakers' bios were sent to you by email. During their presentation, we ask you to please take notes, and when you have a question, please put it in the chat box or in the Q&A box, and there will be time at the end of the presentation for the physicians to respond. Thank you so much for joining us and spending your lunch hour with us. And with that being said, I'd like to introduce our first speaker, Dr. Andrew Ross.
Good afternoon. You guys have me all set? All right, next slide, please. So I'm really going to talk mostly about prevention and screening. Delayed screening can increase the risk of colorectal cancer. Colorectal cancer occurs in the United States in about 1 in 25, and in fact, is the leading cause of cancer deaths in those under the age of 50. So the importance of screening cannot be overemphasized. Next slide. As I said, it's on the rise, particularly in young people, and by the year 2030, it's going to be the leading cause of death in those between the ages 20 and 49 of cancer. Next slide, please. So once again, 1 in 5 cases of cancer occur in young people. So the importance of screening cannot be overemphasized. Next. So who's at risk? Age 45 or older? Do you have a family member who has a history of colon polyps? Do you or a family member have a history of colon cancer? Or do you have a chronic inflammatory bowel disease, such as ulcerative colitis or Crohn's disease? Those patients with those particular situations are at increased risk. Next slide. So, how do we screen? As I'm suggesting here, the most important tool we have right now is colonoscopy. Colonoscopy is the gold standard screening examination. All other modalities have to be compared to colonoscopy in terms of accuracy. But not only is a colonoscopic examination diagnostic, if a pre-malignant lesion such as a polyp is found, it can be removed at the same time. Next slide. Other risks. Do you or a family member have a history of ovarian, endometrial, or gastric cancer? Afro-Americans and Hispanic Americans also seem to have an increased risk. Next slide. Screening can prevent colorectal cancer, and other healthy lifestyle choices can help. We suggest regular screening at the age of 40, starting at the age of 45, exercise and a normal body weight, fruits and vegetables and high fiber foods, avoid foods that are high in fat, such as processed meats, and don't smoke and drink alcohol, only in moderation. Next slide. So I've been doing this for a long time, and these are the top 10 reasons that I've found for people to try to avoid doing colonoscopies. Number 10, I'm too young to have a colonoscopy. Just as I previously stated, screening for colorectal cancer is recommended for people at the age of 45. If you have a first-degree relative who had a cancer at a young age, you might even consider doing screening early. Number 9, I don't have a family history of colorectal cancer, so I don't need a colonoscopy. Most colorectal cancers are in patients who do not have a family history of disease. The majority of patients with colorectal cancer are the first ones in their family to have this kind of cancer. Number 8, I've just had a little bleeding. Bleeding is abnormal regardless where it's from. The misnomer that bright red rectal bleeding is nothing to be concerned about is probably not true. Please speak to your doctor and have this evaluated. Many colorectal cancer patients experience bleeding that was attributed to just hemorrhoids, only to find out after down the road that the bleeding was coming from a cancer. Next slide. Number 7, I haven't had any bleeding, so I don't need a colonoscopy. Once again, most colorectal polyps and cancers don't actually cause bleeding that we can see. Screening can detect growths before they start to cause bleeding. Number 6, I don't have health insurance to cover the cost of the screening. This is obviously problematic, but many providers are affiliated with hospitals that have screening outreach programs that may cover screening. Number 5, I had a colonoscopy 10 years ago and I don't need further screening. If you had a normal colonoscopy 10 or more years ago, it is time to plan an updated screening exam. Number 4, I can't drink that clean out solution. This is obviously one of the biggest concerns of most people. Today, there are different ways of cleaning out the system before undergoing colonoscopy. Speak to your provider, because if you have an issue with drinking large volumes of fluid, there are other options. Next slide. I'm too old to have a colonoscopy. Screening is recommended for most patients up until the age of 75. Healthy patients between the ages of 76 and 85 also may be considered for screening. I think that probably this age issue has become too problematic in that AARP and some of the senior citizen organizations have said you don't need an examination after 70. Well, I think we need to kind of temper that with the idea that many people nowadays at the age of 75 and 80 are in excellent health, have significant longevity, and that colon cancer is modestly common in older people. So not to do a routine colonoscopy just because you're quote unquote older is probably not appropriate. Number 2, colonoscopy is too risky. For the vast majority of patients, colonoscopy is a safe procedure with a very low risk. The complications are minimal and the benefits are obvious. And number 1, the wait time is too long to be seen and set up a colonoscopy. You know, we've endeavored to try to get patients in as fast as we possibly can. And if there is an issue, some providers provide telehealth options for pre-procedure, and many providers don't require a formal pre-procedure visit for healthier patients. So please seek out care as soon as you can. Next slide. Same thing. Next slide. There are alternative methods such as DNA stool testing, Cologuard, which you've seen the advertisements on TV, or Hemocold slides. While easier, are less accurate and are not therapeutic. If these tests are positive, the next step is a colonoscopy. These tests are not indicated for patients who have more than average risk, or those patients who have significant family history, prior history of polyps or cancer, or rectal bleeding. Next slide. Symptoms to be concerned about. Colorectal cancer is often a silent disease. Symptoms to be concerned about include blood in or on the stool, any change in bowel habits. If you're normally constipated and going more frequently, that's truly a change in bowel habits. Stools that are narrower than usual, or general stomach discomfort, bloating, fullness, and or cramping. Next slide. Other symptoms of more advanced disease are vomiting, gas pains, weight loss for no apparent reason, as I said, rectal bleeding, constant tiredness or new fatigue during activity that was previously tolerated, which might indicate anemia, from occult blood loss. Next slide. So once again, these are common signs of colorectal cancer. Change in bowel habits, cramping or abdominal pain, rectal bleeding, even with bright red blood, blood in the stool, which might make the stool look dark, brown, or black, weakness and fatigue, unintended weight loss, and a feeling that you have to have a bowel movement and cannot. So basically, the takeaway from this discussion is that there's a tremendous importance in early detection and prevention, and colonoscopy is the standard of care.
Thank you, Dr. Ross. Dr. Cariff?
Hi guys, can you hear and see me okay?
Yep.
Yes.
All right, great. Let me go ahead and get our screen share going on my end. I've got a pseudo work set up here. I'm taking call in our community hospital, so hopefully you can hear and see me okay. Let me just go ahead and get the slides up. Okay, thanks so much. I want to thank everyone for organizing this very timely and important webinar. And it's nice to see Drs. Ross, Dr. Taylor, and I all back together to do this after we did about a year ago, last March as well. I wanted to touch on some topics related to colorectal cancer education for patients. And while the topic of screening is incredibly important, Dr. Ross already shared with you guys the very alarming data, especially in folks of my age, folks under age 50, where the rates of colon and rectal cancers are scarily increasing. We really need to make sure we're keeping up to date on our screening colonoscopies. I wanted to talk a little bit about some of the treatment discussions we have in the clinic, and how we can kind of package these for patients to make sure that they're informed throughout their treatments. So the first kind of message of the three I'd like to leave with you all today is that biomarker testing is imperative in these diseases. And the reason for this is because we keep seeing data, even since I chatted with you last year, there's been a new targeted therapy approval for patients with resected, stage 2 and 3 cancers, with a drug as simple as aspirin. That's not even included formally here on the slide, but we'll get into it. But we really need to make sure we understand the molecular makeup of each and every tumor so that we can deliver very timely and precise oncology care to patients. So without going through this in a lot of detail, I want to talk to you all about a couple of the genes that we're routinely looking at when we're looking at pathology specimens and when we're obtaining what we call next generation sequencing or very sophisticated molecular analyses based on tumor types. The first would be kind of looking at a patient's RAS status, and this is very important because depending on the RAS wild type or mutation leads to which of the targeted therapies we can look for patients to add on to chemotherapy backbones. If you go all the way to the right, you'll see we talk about these drugs called anti-EGFR antibodies or anti-VEGF antibodies, which aren't explicitly listed on this slide. And this is so important because especially for patients with metastatic disease, we add these drugs routinely in the first line or first start of therapy for patients because we know that it helps patients live longer and better. So this is imperative that we know this. If we go towards the middle of this diagram here, looking at these four other biomarkers that we see here, the one is called microsatellite instability high or MSI high. And this is very important to know because there's a large segment of especially rectal tumors for which we see really nice responses to immunotherapy alone. And for these patients, it's important we know this up front so we can deliver the correct therapy to this unique type of tumor. There is another gene here called BRAF V600E, which is so important to identify because not only is this gene affiliated with a little bit more of a distinct biology of disease, namely what we call right-sided colon tumors, especially sometimes a higher risk of recurrence, especially in patients who have had resected disease. We also have targeted therapies for these. We have what we call tumor agnostic approvals for combinations of pills for metastatic disease with an old set of drugs, which is for all disease, including colon rectal cancers. But we have a relatively new full FDA approval, even since we've chatted about this topic last year, for a new oral drug as well that we can add to chemotherapy combinations. So important we know this upfront. The next one we'll see is ERBB2, also known as HER2. So, if you or a loved one has had a journey with breast cancer previously, you'll know that this is such an important biomarker in all breast tumors because we have targeted agents like trastuzumab, Herceptin, pertuzumab, Perjeta, trastuzumab, deruxtecan, and HER2, etc. And actually, we can use these drugs in colon and rectal cancers as well. In fact, in most GI cancers, there's actually just been a new FDA approval in biliary tract cancers for a novel drug in this area, and we're expecting this in the gastric and esophageal realm very shortly as well. So very important we know this status upon diagnosis. And then fusion positive. So there are these rare subsets of tumors, things like we call NTRK, for which we actually have pills that are available to patients. And then, of course, we can have more than one at the same time. This sometimes happens. And that really opens up the doors for a lot of novel combinations for therapy where sometimes we don't have to use chemo at all, which I think is a nice segue to my next slide, which is that there are options beyond traditional chemotherapy. Here at LCI, we serve Southern Palm Beach County, routinely serving or physically located in the cities of Boca Raton and Delray, but serving patients as far south as Broward and occasionally even North Dade County, and then going up into other counties beyond Palm Beach as well. And accordingly, we do have a fair amount of patients who are part of our geriatric population, so ages 65 and beyond, 80 and beyond. And a lot of patients are understandably concerned about chemotherapy. They've seen the development of chemotherapy before I was even born, frankly, and they've seen how we were not necessarily as great at managing the toxicity from these drugs. We've made leaps and bounds in this area such that I don't feel that the fear here is always something to be so concerned about that you decline therapy entirely. But if that's your preference, we do have options for you. So again, what I've shared with you is some of the therapies already, which are what we call the targeted therapies. So for instance, we talked about from the top left, the VEGF inhibitors. These are drugs like bevacizumab, Avastin, which we can use for patients depending on their RAS status. And speaking of RAS, if you go to the right one, there is another gene called KRAS G12C, for which we have a approval for 2 oral drugs, adagrasib, sotorasib, as well, that we can add to chemotherapy or to targeted agents specifically. We talked about BRAF V600E on the right already, and then its kind of cousin slash brother, BRAF non V600E. Again, the combinations here of dabrafenib and trametinib hold pan tumor approvals such that we can use them in any disease setting, but specifically the drug encorafenib has recently received a full FDA approval to be used in BRAF mutant disease upon metastatic diagnosis, which is so important. On the bottom right here, we touched on HER2 already, very important. In addition to trastuzumab and in HER2, for which the latter we're seeing trials currently, there is already an FDA approval for a drug called tucatinib in this disease setting, which we use routinely in practice. And again, novel drugs, bispecific drugs are being used in this area. So stay tuned because we anticipate some more approvals coming up. I talked about MSI high, macrosatellite instability high. A related biomarker is called mismatch repair, especially when it's deficient. This DMMR, they're very similar DNA mechanisms we won't get into for now, but essentially these patients do have a pan tumor approval for Keytruda, pembrolizumab to be used, but specifically I was mentioning in that rectal subset, there's a really nice response rates we're seeing in patients with localized rectal cancers as well, such that we can avoid chemotherapy in that area. We talked about NTRK, very rare disease type. You can see, 0.7 to 1.5%. We do have drugs, entrectinib example of one of these for which we have pills that are approved. And then we talked about the tumor mutational burden as well. Keytruda specifically has a pan tumor approval here. So bottom line here, there are options beyond chemo, although chemo's pretty good and it has a unique place in this disease. So it shouldn't be something to be feared, just managed very appropriately. The last thing I want to talk about is the evolving role of liquid biopsy. And this is so exciting. We use liquid biopsy in a lot of disease types that we treat in oncology in 2026, and we'll continue to do so. But I think these colon and rectal cancers might be the only tumor I can think of off the bat where we actually have a full FDA approval of the entire spectrum of disease where we can go ahead and use liquid biopsy. So The topic of today, of course, is screening. We indeed already have a liquid biopsy FDA approved for this condition for colon and rectal cancers. This is through a company called Guardant. They can go ahead and do a liquid biopsy for you to see if you're at increase for colon or rectal cancers, if there's any DNA being shed. At that point, you do go for your colonoscopy. You need a tissue diagnosis to be sure, but this can be very helpful. And in the early stages, we can go ahead and obtain these liquid biopsies to see if there's any DNA, especially some of those mutations we've talked about in the neoadjuvant setting before surgery. The field is shifting to sometimes do what we call downsized tumors before resection. In colon cancer and rectal cancer, we do this routinely already for patients for which this is approved. Very interesting. And again, in GI cancers, we're somewhat very blessed that we have so much data to show that there's a role for molecular residual disease, meaning if there's any DNA left after definitive treatment, whether that be chemoradiation, whether that be surgery, a combination of all three, this helps us understand a patient's prognosis and risk for disease recurrence down the line. And through that monitoring, we can also see, God forbid, if disease returns or is advanced already on presentation, such that we can't necessarily be curative in intent, but we can be palliative in intent, make sure that we really help out with patients' quality of life as we're undergoing treatment. And when we look at these either relapse or presentation with metastatic disease, it helps us understand monitoring disease response and seeing down the line if there's any new mutations that pop up, which we call acquired resistance, such that we can change the patient's treatment strategy. So liquid biopsy is mandatory at all stages of colon and rectal cancer, per my opinion. And I do use it for the vast majority of my patients where appropriate. So again, just a quick overview of my three take-home points for everyone. First of all, biomarker testing is imperative. I think I explained to you why that is. Second of all, there are options beyond traditional chemo if that's what you desire, although don't be afraid of it. We can help manage you, and I can offer this to you in a safe way most of the time. And the last thing is that liquid biopsy is just so important in this disease, especially in a screening application, not dissimilar to what Dr. Ross was sharing with us a few minutes ago. So I'll go ahead and end there, stop my share, and I'm happy to take any questions at the end. Thanks, everyone.
Thank you, Dr. Cariff. Now we'll hear from Dr. Ross Taylor, radiation oncologist.
Great. Good afternoon, everyone. Let me share my screen. Perfect. Okay. Well, no, I've got big shoes to fill. This has been really informative from Dr. Ross and Dr. Cariff in regards to where we are with screening and sort of the changes that have happened as we see an increased incidence, especially in younger folks. And of course, Dr. Cariff's points about the continued improvements we have in systemic treatments. So I wanted to focus a little bit more on obviously the radiation aspect of cancer care for colorectal cancers, some updates in 2026 in regards to how we can de-escalate many times in terms of needing all three components of cancer care, i.e. surgery, chemotherapies, and immunotherapies, as well as radiation. So, radiation, when we talk about it in the context of rectal cancers, it's being used in a definitive setting. It's usually paired with chemotherapy. And we'll talk a little bit about what non-operative management means and who can be candidates for this dual modality treatment. For locally advanced rectal cancers, really the standard has been, the new standard has been total neoadjuvant therapy. We'll talk a little bit about what that is and how it plays a role in downstaging or decreasing the size of some locally advanced rectal cancers. And then lastly, radiation can be used in a palliative setting when disease spreads outside of the primary site and can be very efficacious in regards to symptomatic sites of disease. So where are we in terms of the treatment paradigm for rectal cancers? Sort of this is the big picture here. You can see that, ultimately for screen detected early stage rectal cancers, oftentimes surgery is sort of the standard of care. Chemotherapy, radiation, oftentimes not needed. When we get into the locally advanced stages, so oftentimes large tumors that are invading nearby, or node positive, we talk about trimodality therapy. So total neoadjuvant therapy, what that means is a combination of chemotherapy as well as chemoradiation. And the thought with this, and the data shows that we have a high rates of response in terms of tumor decreasing, oftentimes having what we call a complete response. We know that these regimens are beneficial in addressing microscopic disease that may not be visualized on our standard imaging protocols. And we'll talk about the data, but there are patients that can be eligible for what we consider organ preservation. And why that's important is, certainly for low-lying tumors, permanent colostomy is oftentimes sort of a consequence of a curative treatment. And the data does show that improved compliance with chemotherapy when you offer it in sort of an upfront setting. So what is non-operative management? So you can see here we have a locally advanced, I don't know if you're able to see my arrow or not. Is that on the screen?
Yes, yes, we can see it.
Perfect. So we have a locally advanced tumor. We have our standard workup, and as Dr. Cariff mentioned, molecular testing that further can give information about targeted agents. And then we start with total neoadjuvant therapy, which again is usually started with chemoradiation over the course of 5 weeks, followed by consolidative chemotherapy. Now we see this sort of cross section here where the standard has been surgery. Well, what is this non-operative management? So this is sort of a watch and wait approach, and it's for a very specific patient population that achieve what we call complete response after the neoadjuvant therapy. A caveat of this management is a very intensive surveillance protocol, and we'll talk about what that entails. So why have we started to consider non-operative management? Well, a trial that came out in 2023 sort of looked at this regimen. So patients would either get induction total neoadjuvant chemo and radiation, or they get consolidative. What that really means is it just is a change in sort of the order of what they receive their chemoradiation and their systemic treatments. The primary endpoint was looking at the 3-year disease-free survival. And so what we see here in the results is, regardless of whether it was induction or consolidation total neoadjuvant therapy, the disease-free survival, as you can see, was about 70%. What we saw was that organ preservation was a little bit higher in the consolidative total neoadjuvant arm. However, the takeaway here was about half of the patients, the TME-free survival was about 50% between the two cohorts, meaning that patients did not require salvage surgery. There was some regrowth, but in those patients who did have regrowth of the cancer, salvage TME was performed at that time, and the long-term data showed that there was no compromise of overall survival in those patients. So what we get from that is this trial sort of showed that non-operative management is safe in a very selected group of patients. And ultimately the sequencing of consolidative total neoadjuvant therapy was slightly improved in terms of organ preservation compared to that of induction. So where are we now, a year later, in 2026? So I think in December of this past year, the no-cut trial results were published. And much like the OPERA trial, this was looking at non-operative management. So patients underwent upfront chemotherapy followed by chemoradiation and had a response assessment. Unlike the OPERA trial, this trial was very, very stringent on who they considered for non-operative management. So only those who had a clinical complete response were eligible for non-operative management. On the OPERA trial, they allowed some near complete response patients to undergo non-operative therapy. Primary endpoint was 30-month distant relapse-free survival. Ultimately, when we look at the results here, 26% of the enrolled patients achieved a complete response on evaluation after total neoadjuvant therapy, and then went on non-operative management. When you look at the 30-month distant relapse-free survival, you see a really nice 95% did not show any evidence of increased metastatic risk. What was also important on this trial, as Dr. Cariff had mentioned, this trial actually used ctDNA and found that it was predictive of sort of these patients that would fail. Now, when you look at the non-operative management patients in this trial, it was certainly lower in terms of organ preservation. However, remember that these patients ultimately had to have a complete clinical complete response as opposed to the OPERA trial that allowed for near complete response. So I think it's important, as we're talking about omitting what has been largely the curative component of locally advanced rectal cancers, we need to sort of really be screening patients who are appropriate for this management. So patients who have stage 2 or 3 rectal cancers, typically those who are large, limited nodal involvement, and no higher risk features can be candidates. In terms of the location, generally we want to select patients who otherwise would have a morbid surgery, likely requiring permanent colostomy. And so there's carefully selected patients in regards to sort of tumor location and staging. Now, when we talk about patient factors, we obviously want patients who are otherwise in good shape, but it's important to understand the willingness to accept the intensive surveillance that they will require after undergoing chemotherapy and radiation. So this is from the most recent guidelines in terms of surveillance. And so I just wanted to bring this up to show sort of how intensive it can be. We know that regrowth occurs most frequently within the first 2 years. And so you can see that obviously appointments and labs every 3 to 6 months, digital rectal exams, sigmoidoscopies every 3 to 4 months, pelvic MRIs every 6 months, as well as full body scans every 6 to 12 months. As we get further out and see no evidence of recurrence, then things sort of become less intensive. But as you can see, through 5 years, things are quite intensive. And so that's a really important factor when discussing sort of patients and having discussions with patients about truly what non-operative management is. Lastly, just wanted to talk about radiation in terms of where we are technologically. We're very lucky here at Lynn Cancer Institute that we have some of the newest technologies. And really this is just about the ability for us to target the cancers and limit toxicity to the nearby structures. And so We have really good onboard imaging with our newest machines. We have really advanced techniques in terms of how we get radiation to tumors and avoid critical structures. And so we continue to advance in terms of our technologies in radiation oncology, and it only further prevents long-term sequelae of treatment. Okay, I'm happy to answer any questions anyone may have.
Thank you. Let's see, any questions? I know I put a couple questions in. Can you see them, doctors? Or I can read them if you want.
Jan, I wanted to take your first question since I brought it
Okay.
up. Actually, I'd like to share my screen in the spirit of keeping things free of commercial bias. I'm actually just going to share an FDA approval for that liquid biopsy I mentioned. Can you see my screen?
Not yet.
All right.
There we go.
Okay, so this is from the FDA. So this is from the US government, free of commercial bias. So this is the liquid biopsy I was mentioning called the Guardant Shield, and this is fully approved for colorectal cancer screening. Now, I want to focus on a couple of things. This isn't appropriate for every single person, and they actually go ahead and explain who it is appropriate for. So let's answer the reverse. Who should we not use this for? This should not be for under age 45 at this point, because that's where colorectal cancer surveillance is started and recommended. Although we all know in the field we're expecting that age to be lowered to 40 quickly. But if you are under age 45, this isn't for you. If you have a history of cancer, especially colorectal cancer previously, this isn't for you. You're already at higher risk, like Dr. Taylor was just sharing with us based on his data. If you've had a positive result from something like what we call a fecal occult blood test, or other sorts of immunohistotesting from the feces, this isn't for you. If you have a genetic history or condition, some sort of inherited gene, and you know you're at higher risk, this isn't for you. But for those who it is for, which is patients, what we call at average risk, this can be helpful. And specifically, the way to look at these is that we see a good result in about 83% of patients, such that we're able to detect if there's anything in the blood at that time. But keep in mind that 1 out of 10 will have a false positive result, okay? So this is important. They even write negative shield results do not guarantee someone does not have colorectal cancer. These are the limitations of biopsy at this time. There are newer platforms that are coming, but this is what's available. To Dr. Ross's point from earlier, colonoscopy is how we diagnose this. This is a screening test. Those are not the same. But if you're really worried about the colonoscopy and you don't abide by his 10 nice reasons as to why you should go get it, this is a start.
Okay.
So can I just respond a little bit? I believe these other tests, particularly the Cologuard and the DNA Shield test, are are reasonably diagnostic of actually colorectal cancer, but pre-malignant lesions are probably the question really here, whether or not polyps are detected by these tests. Uh, and with all this, it's the same as with mammogram. Early detection is the most important aspect of all this. So I think a lot of these tests may be somewhat accurate for people who already have colon cancer, but I think the issue really is the prevention of it.
Right.
Yeah, and I want to just agree with what Dr. Ross is saying. I think if you look at Cologuard, its sensitivity for things like advanced adenomas is drastically reduced. I think it's in around 40%, whereas obviously colonoscopy is probably greater than 95%.
It should be, yes.
Yeah, I asked my questions basically to figure out how we reach the younger population, and for things like that I do out in the community, and it's hard to reach the mass majority of people.
One of the things, unfortunately, that probably kind of promotes this whole idea is we've seen in recent history. Recently, there was a young actor who died of colorectal cancer. Um, some fairly high profile. Years ago, there were some high profile Major League Baseball players with colorectal cancer at a young age. So we tended to see a significant increase in interest in screening at that point, but the idea was to keep this in the public's eye.
Right.
Absolutely.
Well, thank you all so very much. Oh, did somebody else, Dr. Taylor, did you have something?
No.
Okay. We appreciate this so much. Anybody else have any other questions? I know this was so thorough. And one of the benefits of our presentations that we have on Zoom is that they are recorded. So anyone that has been able to tune in, you can refer back to this presentation, or you can share it with other patients, family members, or friends that you feel this would be beneficial information. We should probably, those of us that are older, should probably all send it to our kids. So, and Lee will be sending out an evaluation. We appreciate all our participants to complete that. And if you would like a copy of this presentation, it should be ready by the end of the week, and Lee will send you a link. As I said, thank you for joining us today. And for April, I just wanted to give you a little heads up on what we're going to be, the presentations for April. On the 15th will be from our survivorship series. We will have Anita and Caitlin from the Drummond Therapy Centers working or presenting on rehab after head and neck cancer. On Thursday, April 16th, from our support services department, Elsa and Anne our licensed clinical social workers, will be presenting on the power of advanced care planning, the advanced directives. And on Friday, April 17th, from our physician panel series, Understanding Head and Neck Cancers, from Diagnosis to Treatment, will be presented by Dr. Michael Glahn, Dr. Ross Taylor, and Dr. Matthew Matten. So thank you, everyone, for spending time with us today. Thank you, doctors. We appreciate all the time that you put into this. You're very generous with your time and expertise, and we're very grateful. Thank you, everyone. Have a good rest of the day.